tooth preparation rules and theory. The aim of this presentation is to implement the preparation guidelines for all ceramic restorations, to learn the different preparation forms, and to know the correct indication for the corresponding preparation forms. Overall, these guidelines should lead us to achieve minimally invasive and long-term restorations in our patients. Here we follow the basic rules for the preparation of all ceramic restorative forms. It should be noted here that everything from the proximal box base to the parapulpal walls should be rounded and there should be no sharp edges. The same applies to the cavity walls up to the cavity bottoms in order to avoid notch stresses in the ceramic, and also to facilitate the fabrication with CAD/CAM systems. On the left side you can see the wrong preparation shape. This tip cannot be produced by CAD/CAM systems and it leads to stress peaks in the ceramic at this point. However, on the right side you can see rounded shapes. These are easily reproduced due to the cutter radius used in the CAD/CAM system. The next picture shows us the cavity from the occlusal view. It should be noted here that the opening angle to proximal and buccal surfaces should be 90 degrees in order to minimize leaking ceramics and the associated fractures. If you look at the cavity from the proximal side, you should aim for an opening angle of 6 to 10 degrees. An opening angle of more than 10 degrees increases the risk of a fracture of the ceramic at the transition to the occlusal surface. Let's speak about reference shift. You must prepare the deepest point of the fissure with the corresponding depth right at the beginning. In order to avoid this, there are corresponding diamond grinders from various manufacturers, such as the Comet Company and the Meisinger Company, with depth markings lasered onto the instruments. The lasered depth markings enable us to guarantee sufficient penetration depth when opening the central fissure for the first time in order to achieve the minimum layer thickness of the ceramic later on. These pictures once again show the schematic representation of the laser engraving of the preparation diamonds. These depth marks, which we see here, are often lasered into the instrument at 2 mm and at 4 mm. We now start with the rules for the preparation of ceramic inlays and partial crowns. Here, we must always make sure that the minimum layer thicknesses of the materials used can be taken from the corresponding data sheets of the manufacturers. The following picture shows a schematic representation of an inlay preparation. This inlay preparation is to be restored with the material Cerec Tessera. Dentsply Sirona specifies a minimum layer thickness of 1 mm for the ceramic restoration in the area of the fissure. Outside of occlusal contacts, the material layer thickness can even be reduced to 0.8 mm. If we now look at this inlay preparation from the occlusal view, it should be noted that the width of the ceramic at the occlusal isthmus should be at least 1 mm with the Cerec Tessera material. Now we look at the preparation of the proximal boxes. The proximal boxes should always be separated. Separation ensures that a good scan or impression can be made. Furthermore, you have a better possibility of removing excess after adhesive cementation and the accessibility for the subsequent polishing of the ceramic tooth hard substance transitions. For occlusal preparation, rotary instruments are optimal and effective. However, this is different when we work on the proximal area. Here, the rotating instruments protrude significantly beyond the preparation margin. This often leads to injury of the adjacent teeth. In order to protect the neighboring teeth, metal matrices can be used here, which are clamped around the teeth that are not to be prepared. It is even easier to use sonic tips for the preparation of the approximal boxes. The Cavo Sonic Flex system should be mentioned here. For this system, there are sonic tips for the mesial and distal box. It is important that these instruments are only used on one side and the neighboring tooth is not injured. In principle, a pre-preparation with rotating instruments would take place and then the finishing with the sonic tips. Depending on how wide the box is, for example, a molar or premolar preparation, these sonic tips are available in different sizes. A feather edge or bevel edge should never be prepared, as this will cause the ceramic to burst out and the minimum layer thickness cannot be maintained. In principle, undercuts or sharp edges should be compensated by a build-up filling for all ceramic preparations. The SDR Flow Plus material from Dentsply Sirona, for example, is suitable for this purpose. The build-up filling should only be applied to the dentin. Build-up fillings that cover the enamel should be removed. The cavity margins for our ceramic restoration should always be in the tooth structure. The box elevation is an exception here. Let us now move on to the transition from the inlay to the partial crown. This picture shows us a preparation for an inlay when the cavity walls in the orovestibular direction are too small. That is, less than 1.5 to 2 mm increases the risk of fracture. To minimize the risk of fracture, these walls should be overcoupled to thin walls. That is, a partial crown is indicated here. Advantages of the preparation of a partial crown are significantly more options for the preparation shapes and the use of a defect-orientated preparation. The focus here should be on the overcoupling of the fracture-prone tooth regions. When preparing the cusps to be overcoupled, we have to make sure that we keep a minimum still thickness for our ceramic restoration. The middle picture shows a schematic representation of the minimum layer thicknesses for the Cerec Tessera material from Dentsply Sirona. Depending on which material is used, the minimum layer thickness can be found in the instruction leaflets of the respective materials and prepared accordingly. Deep, approximal boxes that are not enamel limited are not a contraindication for a ceramic adhesive restoration. In this case, it is only necessary to ensure that drainage is possible, for example, by means of a cofferdam. If it is no longer possible to drain the restoration by means of a cofferdam, these depth boxes can be elevated by means of the so-called box elevation, or DME. You can see a clinical example on the right side, where the distal box was elevated by a deep margin elevation. This is where our restoration then comes to rest in the composite. Furthermore, as with all other ceramic preparations, undercuts and sharp edges should be compensated by a build-up filling. Presentation. Slide 20. When preparing partial crowns, no classic retention form is necessary. The only thing that is important is a clear positional fixation during the insertion. This is also referred to as a defined final position of the ceramic restoration. The most frequent fractures in inlays and partial crowns occur at the transition from the occlusal to the proximal box as shown in the picture on the right. This can be avoided by maintaining the minimum layer thicknesses and by ensuring that the transition from the occlusal to the proximal box is nicely rounded. The left picture shows the fracture line that often occurs at the isthmus. These problems can be minimized by paying attention to the minimum layer thicknesses when preparing the central fissure. We now turn to the preparation guidelines for ceramic veneers. The following pictures now show us 5 different designs for the preparation of ceramic veneers. We speak of non-prep veneers, minimally invasive veneers, semi-invasive veneers, invasive veneers, and Class 3 restoration. The left picture shows a modified disilicate ceramic from Dentsply Sirona, in this case Ceric Tessera. The middle picture now shows us the minimum layer thicknesses that have to be fulfilled for a classic veneer preparation with this material. It can be seen that with Ceric Tessera, material layer thicknesses in the vestibular area of 0.4 mm can be achieved. Depending on the material, the practitioner must take the minimum layer thicknesses from the corresponding information documents of the manufacturer. Special adhesion systems are available for the adhesive cementation of ceramic veneers to achieve even better aesthetic results. Now we come to the preparation guidelines for ceramic crowns in the anterior and posterior region. The next picture shows us a crown restoration in the anterior region using the Ceric Tessera material. Here, a minimum layer thickness of 1 mm must be observed. Basically, if the loss of tooth substance is too severe, there is the possibility of a crown preparation. Picture 1 shows a preparation with a rounded shoulder. Make sure that the preparation angle is as blunt as possible, that is, that the ceramic does not break out. Picture 2. The preparation of a step with a rounded inner edge is more optimal if you want to restore this tooth with a ceramic crown. The pictures A and B show the comparison of the same material. Picture A with conventional cementation and picture B with adhesive luting. This comparison shows us that by using the adhesion technique, a reduction of the minimum layer thickness to 1 mm is possible when we use the Ceric Tessera material. If we are unable to maintain the minimum layer thickness of 1 mm due to anatomical conditions, we have the option of using a different material. In this case, the material Ceric MTL zirconia would be suitable. This is a multi-layer zircon, which gives us even more leeway in difficult space conditions. Here we could reduce the minimum layer thickness to 0.6 mm. Finally, let's mention the most common problems in the preparation of crowns. On the one hand, preparing or not recognizing undercuts, and on the other hand, especially when preparing with chamfer instruments, a so-called groove. Especially in scenes with a small clinical crown or a short clinical crown, the adhesion technique should be your first choice. If drainage is not possible, and therefore only conventional cementation is possible, points such as protection against rotation and the cementation function must of course be taken into account. Deep Margin Elevation Module. Welcome to the Deep Margin Elevation Module. Let us first highlight some theoretical aspects of this type of treatment and go into the advantages of its clinical approach. As practitioners, we are all familiar with the daily clinical problem of deep subgingival cavity margins. The problem with deep subgingival cavity margins is, of course, the violation of the biological width and the resulting practical difficulties when taking impressions or scanning preparations. In addition, it is almost impossible to ensure adequate drainage for adhesive cementation in the case of very deep subgingival cavity margins. For these reasons, deep subgingival cavity margins jeopardize the practical success of our indirect ceramic restorations. At this point, the concept of biological width should be explained once again. What is biological width? The biological width is composed of the connective tissue attachment and the epithelial attachment. It is the distance between the crest edge of the alveolar bone and the coronal end of the marginal epithelium of the gingiva. The biological width is subject to a certain range of variation depending on the localization in the dental arch. A good guideline here is a distance of 2 millimeters. In practical terms, this means that the restoration margin should be at least 2 millimeters away from the crestal margin of the alveolar bone. A practical solution is needed at this point. Moving the deep subgingival margin coronally offers us this practical solution. This allows us to work in a defect-orientated and substance-preserving way. When the crown margin is closer to coronal, scanning is much easier. The secure drainage for the adhesive luting with rubber dam is now usually problem-free. In summary, moving the deep subgingival cavity margin to coronal allows us a much simpler clinical workflow. When considering this clinical procedure, it is noticeable that different terms exist in the literature for one and the same clinical procedure. For example, some authors talk about cervical margin relocation, CMR, or coronal margin relocation, also CMR. Other authors talk about the same clinical procedure via deep margin elevation, DME. The term proximal box elevation, PBE, is also used to describe the same clinical procedure.